Thank you to the Department of Urology at Baylor, obviously, for coming here, having your conference here, allowing us to participate. It's the only urology conference in New Mexico for the entire year. So today I'm going to talk about something probably that you all are thinking, what does this have to do with urology? It will probably impact urology eventually in the future, where renal xenografts will become a thing. So the topic of my talk today is, will xenografts remove the tragedy from transplant? So if you look at the definition of tragedy, tragedy is basically a form of human drama based, or a form of drama based on human suffering. And the transplant space has a lot of tragedy. If you look at it, the donor and donor families go through a tragic event for cadaveric donation. There's not enough organs for the number of recipients out there. And finally, the United Network for Organ Sharing right now is going through major restructuring through the federal government because of allocation and distribution issues. So I'm just going to give a plug for our transplant program. It was started in 1975. The original, or the first transplant was actually done at the VA hospital in Albuquerque. We've done almost 1,800 transplants at UNM, 35% by a single surgeon, and we're celebrating about 50 years of transplant at UNM right now. So the chimera is the symbol of the American Society of Transplant Surgeons, and the chimera was a fire-breathing she-monster in Greek mythology, but it also is an individual organ or part consisting of tissues of diverse genetic constitution, and we're actually kind of moving in this direction. So how do we get here? How do we get to the ability to put a pig kidney into a human being? I'm just going to go through this kind in this talk, going from impossible to possible, going through history, what led to success, immunosuppression, finally gene editing, which along with immunosuppression made this successful, and now preclinical trials. So the interest in transplantation really emerged in surgery in the early 1900s from the interest in vascular suturing techniques. Ullman in 1902 auto-transplanted a dog kidney from its normal anatomic position to its neck, and it made urine, and it was a great success. Then he did actually a xenograft transplant, dog to goat, in 1902 that passed urine for a little while, but after this he just kind of abandoned all work once he knew he could do it. Jubilee, whose mentor was Carrel, if you're familiar with vascular surgery, he carried out the first recorded kidney transplant in a human in 1906, and this was a xenograft using a pig or goat as a donor, and they were transplanted to the thigh vessels of the recipient and renal failure, but the kidneys obviously didn't work long because of immunologic factors, as we know now. And then Unger went on to transplant en masse a fox terrier to a boxer dog, and he presented this to a couple medical societies. And the urine output continued for 14 days now. Then he went on in a desperation move to attempt to transplant a human or a monkey to a young girl who was dying of renal failure from mercury poisoning. And once again, he sutured it to the thigh vessels. This is the diagram here. He made a little stoma for the ureters, but kidneys didn't work, and it was a failure. So we know now, back then we didn't know, but you're kind of putting the cart before the horse, because really what you need to understand is the immunology of rejection. And so immunosuppression was a long way from being developed. And so by the start of World War I, all of the interest in transplantation just ceased. And World War I came, and then World War II, you had soldiers with vast burns who needed grafting, not enough skin, and so it'd be nice if you could, transfer xenograft skin to these recipients. So a lot of research was being done in that. But in 1946, this group, in a move to save a patient's life, took a kidney from a recently deceased donor who died in heart surgery and transplanted it to the thigh vessel, or the arm vessels, of a woman who had acute renal failure from blood loss anemia. And this actually worked for a while and helped her recover renal function, and she went on to survive. Then in the 1950s, we finally got the mechanism of rejection using the dog kidney transplant model, and two researchers kind of defined rejection, and then researched on how to manipulate the immune system so that you wouldn't have failure of the graft. And one thought cortisone was a way to delay this process, and the other thought whole body irradiation was the way to do it. Azathioprine appeared in 1960 thanks to Roy Calm. He was looking for an alternative to radiation for immunosuppression. He showed this was highly successful, but azathioprine alone wasn't successful enough, and Starzl and Goodwin came up with a cocktail of azathioprine and steroids. And this is when allografts really became more successful in terms of their graft survival. And after this, renal transplantation really started seeing success, where you went from kidneys to other organs. Terasaki in the 1960s came up with tissue typing, which helped reduce hyperacute rejection. And then from the 60s all the way through the 90s, you had rapid development of other immunosuppressive agents like cyclosporin, tacrolimus, mycophenolate mofetil, rapamycin, and sirolimus. So this is really what it came down to. This is, how you can manipulate the T cell response, and indirectly the B cell response to prevent rejection. Now fast forward to 2024. As of March 2024, we had about 90,000 people waiting for a kidney, and we transplanted about almost 30,000, 28,000. So there's still a vast organ shortage, as can be seen here. And the imbalance is projected to get worse as end-stage kidney disease increases over time. It's projected to be 29 to 68% and go from 690,000 to over 1 million by 2030. So it's not going away, and if anything, it's getting worse. So where is our donor supply? Well, of course, you have living donation. You have donation through the National Kidney Registry. This is a type of living donation. And then the two cadaveric types are donation after brain death and donation after cardiac death. And we all have seen living donation. Some of you perform it here. You can either use laparoscopic assistance, hand assist, you can use a robotic, and there's single port living donation now. But it's still a risky endeavor for a donor. It still involves risk. The National Kidney Registry is nice because if you're a donor-recipient pair and you're not compatible with your donor, then your donor can donate to a patient maybe out of state, and then a kidney comes to you as payback. So this is nice for donor-recipient pairs that don't match. The Uniform Determination of Death Act came in 1980, and basically it allowed us to define brain death as well as cardiac death. And so really now there's two ways to donate. You have deceased organ donation, so you have donation after brain death or donation after cardiac death. And both, as you can see here, involve severe neurologic injury. So the difference is donation after cardiac death, basically patients have a severe neurologic injury, and they will expire if cardiopulmonary support is withdrawn. So here's more of the tragedy. Obviously, in transplantation, you've got something awful has happened, causing either brain death or donation after cardiac death. We see a lot of overdose, brain death as well. So in brain dead donors, they meet obviously strict criteria for brain death, and donation after cardiac death, it's up to the family to kind of withdraw support. The nice thing about brain dead donors is there's not really a period of warm ischemia, meaning during the procurement, the heart remains beating as the dissection is done. The organs are all being oxygenated. And this is just an example of the empty skull sign. This is a scan showing a brain dead patient in the middle, and you can see a healthy control and kind of a comatose state on the right side there. So the difference between that and donation after cardiac death is the family's decided to withdraw support, the patient's taken to the operating room, cardiopulmonary support is withdrawn, and then the teams just wait until asystole. Once asystole is pronounced, you wait 5 minutes, and then it's a really fast operation. You have to rapidly cool organs, put in flush, etc. So the key elements in donation after cardiac death really is a pronouncement of death and waiting to define death after asystole, and usually time to asystole. For a liver is only 30 minutes before a liver is probably gone through too much warm ischemia. And kidneys, we give 60 minutes, but some programs give up to 120 minutes. So DCD donors have increased our donor pool quite a bit in the past 2 decades. It now represents about 32% of deceased donors, so it has increased the donor supply. We've expanded donation with hepatitis C positive donors, HIV to HIV transplants, older donors, and even donors with acute kidney injury that's recoverable. But you still have, in terms of organ allocation, this was an article in the Wall Street Journal about approaching patients that have not expired and ethical issues. This came out from the congressional hearings on the United Network for Organ Sharing and some of the big problems they're having with organ allocation. So this is, like I said, more of the tragedy in transplant. So really, if you look at the supply, we have living donors, DCD donors, and brain dead donors amount to the kidneys available, but unfortunately it doesn't meet the organs needed right now. So we're hoping that with development of xenografts, maybe we can bridge some of the gap, maybe not all of it, but make it more, have more kidneys available for the recipients who need them. So why choose pigs as a source animal? Pigs were chosen as the best option due to their unlimited availability. They have similar anatomy and physiology to humans. They have lower risk of zoonosis or transmission of infectious disease. And this table just shows why they're advantageous. So the pig, the availability is unlimited. They have great breeding potential. The period to reproductive maturity is only 4 to 8 months. The length of the pregnancy is short, and the number of offspring is actually, they have litters, so you can have the reproductive capability is good. Physiologically, they're similar to humans. So this is a good supply for these xenografts. The barriers, though, to xenotransplantation include all of the following, the biggest one being xenoantigens. Finally, incompatibility of pig and human proteins, cellular and antibody-mediated rejection, as well as infectious disease. So the thing that had to be overcome before this could even be thought of is getting rid of xenoantigens, which cause hyperacute rejection in the recipient. And that's basically just immediate thrombosis of the graft due to antibody-mediated response. And the big thing that causes this is the carbohydrate 1,3-galactose on glycoprotein glycolipids in the cell membrane. And then there are other xenoantigens that are as important, like blood group antigens, the 2 listed here. So 3 pretty important xenoantigens that cause hyperacute rejection. So in order to make this successful, pigs have to be genetically modified to knock out these 3 genes. So they're called triple knockout organs. And this allows a negative cross-match in patients awaiting transplant. Other demonstrated xenoantigen include swine leukocyte antigen. You've all heard of human leukocyte antigen. That's one of the things we have to check for kidney cross-match. Well, there's swine leukocyte antigen that can actually cross-react with human leukocyte antigen and cause rejection. There are proteins that still need to be researched, thrombomodulin, tissue factor pathway inhibitor, and pig von Willebrand factor, all things that can cause issue. And then finally, further research is needed in these enzymatic systems like angiotensin, erythropoietin. Is it similar enough that will cause bone marrow stimulus of red cell mass, antidiuretic hormone? And finally, pig kidneys can maintain most physiologic human electrolytes, except there's a slightly elevated calcium and lower range for phosphorus. So one of my questions is, will we see more like renal stone disease in xenografts? And the other thing is these organs without genetic manipulation will grow to large size. So you have to kind of limit their size. And this is just an example of some of these areas of stimulation of cell and antibody-mediated rejection. Even post-hyperacute, ruling out hyperacute rejection, you can still get T cells recognizing the swine leukocyte antigen and cross-reacting with human leukocyte antigen. Finally, risk of infectious disease. Obviously, this is what you hear, I think, mostly in terms of xenografts is, could this cause another huge issue in terms of infectious disease? And so you have to take very large steps in terms of precautions with breeding and care of these pigs in facilities, all that can be seen here. The only thing you can eradicate really is porcine endogenous retrovirus, which is intercalated in the pig DNA. But despite this, in over 200 transplants from pigs to non-human primates and 200 to human transplants, there's been no documented evidence of transmission of porcine endogenous retrovirus. So the current best practice in pig xenotransplantation is the 10 knockout gene, or the 10 gene edited pig. So you do the triple knockout of the xenoantigens, and then you add complement regulatory proteins. You also want to utilize anti-CD40 antibody during your induction phase. And this just shows a timeline basically of now where we've come. So you can see back in the 1600s, we were interested in xenotransplantation, and it's taken this long to get to where we are. So now I'm just going to go into the most recent cases of xenotransplantation, some preclinical trials that have been done. The first case was from Porrette and her group at University of Alabama. They started a xenograft research facility in 2015. And they developed a decedent model, a preclinical trial in brain dead donors who otherwise could not be eligible for organ donation. Obviously, they had to be over 18 years of age, family had to consent. They were ineligible for donation. And really their questions in this study were pretty basic. So the first question was, is the current suite of porcine genetic modifications sufficient to avoid hyperacute rejection in humans? Could flow cross-matching prevent hyperacute rejection? Would there be life-threatening that we didn't know about intraoperative complications during a renal porcine xenotransplant? Would you be able to detect cells or pathogens after transplantation? And finally, could this be safely performed under conditions necessary for a future clinical trial? And these were kind of the metrics that they looked at after transplantation. And so the way they conducted this is the pig kidneys were, and they're from a company called Revivicor. They were procured right next to the operating suite of the decedent. And the decedent was an adult greater than 18 years of age. Next of kin actually had to authorize the research, obviously, and then they had to have a negative cross-match with the donor pig. And this is the actual individual who was involved in this research. The family actually had a tribute to him, and this can be found on YouTube. But anyway, they did a very nice tribute to him in terms of his propagating this research. And so this was the animal they used, or the kidneys. They had 4 gene edits, 4 knockouts, and then they added these genes. And so the 3 knockouts were the xenoantigens, and the 4th was for pig hormone growth receptor to prevent growth of the pig kidney. And they added genes that actually influence complement as well as coagulation, oxidation, and inflammation. And once again, our decedent was 57 years old. His cause of death was head trauma. He was not eligible for organ donation. By the time that this study was conducted, he'd been declared brain dead for 5 days. And so in phase 1 of this study, they obviously harvested the pig kidneys. They made the decedent anephric. They removed his kidneys. And then they went ahead and did the transplant, transplanting the right kidney to the bladder. The left kidney was left just open. And then they observed the kidneys for 3 days. And these are just pictures of the right kidney and the left kidney immediately after transplantation. They did make some urine, and then showing post-op day 1, finally to post-op day 3. And really what happened on post-operative day number 3 is the patient, because of his brain, he'd been brain dead for 8 days by this time, the pathophysiology caused disseminated intravascular coagulation. They had to terminate the study. But the questions that were answered of this study was, yes, you could do this using genetic modification. There was no hyperacute rejection. Prospective cross-matching did work. There was no life-threatening issue in terms of devastating cardiovascular collapse after revascularization. They did not detect any porcine cells or pathogens in the blood of the decedent. But was it ready for a clinical trial? Probably not yet. Now, at almost the same time at NYU, Dr. Montgomery did a same type of trial, once again using Revivicor xenografts. And what the interesting thing about Dr. Montgomery is he's also a cardiac transplant recipient. So they did their first one in September of 2021 and their second in November of 2021. And each of the recipients of the xenografts, similar to the Alabama study, was declared brain dead by the clinical team. Organ donation was exhausted, and then if the family agreed to pursue the xenograft, the transplant team was notified. They used the same knockout pig model, except they used thymo kidneys. So these were kidneys where thymus was placed in the capsule of the kidney. The thinking of thymo kidneys is that it makes the recipient more tolerant to the foreign tissue based because the thymus influences T cell response. Instead of placing these kidneys in the body or in the pelvic vessels, this team decided to place them to the femoral vessels so that they could be directly observed. So they were placed in the thigh, and the ureter was cannulated, and then urine output could be observed. So this is what they looked like after transplantation. This allowed them to observe them as well as directly biopsy them, when at certain times, and they could observe urine output. Immunosuppression was standard. They gave a standard induction immunosuppression followed by fairly standard maintenance immunosuppression. They did use heparin drips to prevent systemic coagulation. The difference also in this model is they did not make their decedents anephric. So these decedents had their kidneys, but as you can see from recipient 1 and recipient 2 here, their GFR was fairly low at the beginning, and then post-transplant, their urine output as well as their GFR actually improved. So this was showing that these pig grafts could actually maintain renal physiology. Then Dr. Porrette and her group did another study, similar decedent study similar to the first one she did, but in this study in 2023, they added eculizumab, which is a complement inhibitor, and they carried this out for 7 days, and as can be seen in the decedent, serum creatinine decreased and GFR went up to about 200, so very successful model here. NYU reported to the American Transplant Congress this past June about a decedent that they had kept for 3 months with the permission of the family. And in this model, basically they had 1 episode of rejection which was reversed, but what they were able to maintain normal kidney function or renal function. So finally, we had this report. You probably all saw this in the press. This was out of Boston last spring or winter. A 62-year-old man with end-stage renal failure named Richard Slayman. He had received in 2018 a kidney transplant, but it had begun to fail, and he resumed dialysis, but he was having major issues with dialysis, life-threatening issues. And so the transplant team made a plea to the FDA in compassionate use to use one of these xenografts. This xenograft was from a different company called eGenesis, and they modified 69 genes in this pig model. These kidneys had been successfully transplanted into non-human primates, and these had survived months to years. So they used this in Mr. Slayman. And this is just a picture of the transplant team performing this transplant. And this was Mr. Slayman as he was leaving the hospital after successful transplantation and returned to normal kidney function. But then about 4 months later, he passed away. And so the question is, did this relate to his transplant? The transplant team says it had nothing to do with his transplant, but we still have yet to hear a postmortem on him. So anyway, obviously there are ethical concerns with this in terms of clinical trials. Using animals, the cost, what's the cost going to be to use these genetically modified organs? Once again, you have infectious disease, trial design, eligibility, and need for second transplant. And this is just from a paper that went through a lot of these ethical issues. So in conclusion, xenotransplants have the potential to relieve the major public health problem of scarce donated organs. Testing and evaluation approach, xenotransplant approaches through clinical trials is on the horizon. Obviously these kidneys and these organs may be a way to bridge patients to get transplantation from human allografts. But we still need studies to show efficacy and safety, most importantly, long-term survival. Equitable access to xenotransplantation will have to be addressed through, the entities that conduct these studies, including private industry and the public academic centers. And you have to design inclusive clinical trials, selecting centers and patients fairly, and educating the kidney care community in a way that reaches diverse populations. Anyway, it's an exciting time in transplantation. I'm hoping in the next 5 to 10 years that we're able to do this successfully. And there are my references if anybody's interested. So, thank you.